Next, we'd like to welcome Dr. Denis Bouchard to continue the discussion of repair techniques and respect, resect.
Well, thank you. And first of all, thank you for making me a part of this tremendous event. Thank you, Dr. David, for leading us the way of technical excellency and also surgical knowledge, with all the data that you have produced throughout the years. Well, we have already discussed quite a bit about respect and resect. The concept has been brought by Dr. David and Dr. Perrier. Should we cut some of the leaflets and reconstruct the valves, which has been the initial Carpentier technique, or should we add cords and more correct what is anatomically sick? So I'm going to go through a couple of videos quite quickly. We have discussed already quite a bit the concepts. So here that's a case. Guy 67 comes with P2 prolapse. There's rupture cords, obviously, and it's usual in Montreal, me or my friend and colleague Michel Pellerin, who have been doing those mitral valve repair together for many years, have used a bit both of new cordes and leaflet resections. Here, I thought that there was a lot of posterior leaflets and that using presets length of cords after measurement at P1, which looked normal to me, would be the best way to address that sort of wider P2 segment. So, well, those preset cords, they're pretty straightforward to do. The more difficult aspect is figuring out and measuring the proper cords right beside. So now that all the cords have been put in place and tied, I do measurements of the annulus. Two plans for, I know that Patrick McCarthy told me all about those ratios and the pre-calculus of measuring twice, but I usually still use the sizer and use also the both the AP diameters and intercommissural length. Here it's a very, very large annulus, so I use a 42 size ring. And already looking at the valve, I'm not that keen on the P2 because of the proportion, and that's a mistake that you can make using cords, right? So the proportion of the anterior-posterior leaflets has been wrongly calculated. So I've added new cords and lower down the posterior leaflets, because if you just adjust for the proper length, you might end up having more chances of having SAM with the posterior leaflet potentially pressing on the anterior leaflets. Here I do chordal adjustments with the anterior leaflets to better represent how much lower I want to bring the posterior leaflets on this specific case. So having tied it, I partly corrected it and decides that we're going to look on echo if the proportion is correct. And we have good coaptations and no LVOT obstructions. So moving to the second case, it starts very similarly, and that's the idea that I want to bring about resections versus neocords and respect procedures, is that very often it's adaptable one way or the other, or as we're going to see, maybe in combinations. So here the posterior prolapse is a bit more localized. It's a small P2. It's got some rupture cords there and the length of it. And obviously, I could decide now that we're going to preserve that small P2 segment and throw in a few cords. But the segment is so small that I've decided I'm just going to do a V resection, and that's going to take care of the whole of the mitral valve pathology. So now that's the way that Dr. Gilnoff taught me at the Cleveland Clinic. We isolate what we're going to keep with silk sutures, then do the resections and complete the closing. I like to use the running sutures. It just go fast and usually decrease a bit the length of the posterior leaflets, making it better proportions compared to the anterior leaflets. Now cords are being put in, and it's a good post-op result. So for the interest of time, so here we have the water sealing test and the sizing. So I think that those cases set the stage for the third videos that I wanted to show, which is also posterior prolapse now, very similar to the other cases. This one, has no rupture cords and not so normal P3, but with no rupture cords and quite normal P1. So we elected to start with a V resections, and a bit like was discussed by Dr. Adams earlier, after the resections, we were not completely pleased with the height of the leaflets and the potential durability of that specific repair. So I elected, once that leaflet resections and the tying of the two half of the V's have been properly done, to add extra cord days to the procedures on both of the papillary muscles. So for the interest of time, I'm going to save you a bit some of the echoes. Yeah, not a bad result, but still a bit of prolapse that I thought we could get better with sets of cords. So they're more complementary than anything. I don't think that we need to select a camp. No, these are useful tools, both of them complementary. An equilibrium in terms of good results, but definitively could be pieces of puzzles that fix the mitral valve repair for our given patients. Thank you.